allow me to, I don't know that it is a big panel, as we can see, and I'm not sure that everybody is sitting in the place that is listed on my list. So if you will do me a favor, as I read your name, just raise your hand, because I can't see everybody. So we're going to talk about responses and recommendations to ensure safety sexual safety in acute mental health inpatient units, and we do have a big panel because this is an important topic and there are many voices which need to be heard, and so the compromise was made that we would rather have more voices and get everybody to have an opportunity to speak rather than kind of artificially narrow the conversation. So we'll move it around quickly. I think for speed, and because we do have such a large panel, rather than do roving microphones, if you have a burning question, feel free to send it to us via Slido. That will be really helpful. I'm going to introduce our panel, and I'm going to ask that you raise your hand as I call your name, just in case you're not in the spot where you are in my list, because, yes, I think that would be good. All right. Indigo Dea, Human Rights Advisor, Mental Illness Awareness Council. There we go. Julie Dempsey, Secretary, Women's Mental Health Network. Katrina Clark, Board Member, Tandem Carers. Brenda Appleton, President, Transgender Victoria. Sandra Keep, Clinical Services Director at Alfred Mental Health. Penny Herbert, Quality and Risk Manager also at Alfred Health. And we also have with us Professor Daniel O'Connor, the Deputy Chief Psychiatrist from the Office of the Chief Psychiatrist, and Anna Love, Chief Mental Health Nurse. Okay, so not precisely in order, but that's absolutely kind of okay and sort of appropriate. So I'm going to just get started, and I'm going to move it around, and if one of you just thinks that you must add on to something, that just, if you raise your hand, I'll try to call on you. But, we've heard a lot. Obviously, the crucial aspect of this is sexual safety. How do we keep people sexually safe when they're in an inpatient acute mental health unit? So let me start with you, Indigo, if I may. What do you think of the findings and the recommendations? I mean, I heard some of it, it sounds like there are a few people who want to blow it up. But so short of blowing it up, or if you're going to blow it up, how does this mesh with consumers and your concerns?
Okay, thanks very much. Well, first I'll reflect on the findings before speaking about the recommendations. And as I begin to do that, I actually want to start by acknowledging the people who have survived sexual harassment and assault in psychiatric services. Just this morning, I've heard from 4 survivors on social media. And on Monday of this week, I had a call in response to a media interview I did about trauma from a woman who was sexually assaulted in a Melbourne psychiatric service more than 2 decades ago. She wasn't believed when she told staff about it, which I know from many of my friends as well is common. She was discharged into homelessness, and she fled Victoria. So she is still, more than 20 years later, living in another state. She's still homeless, and she still lives in fear every day of her life. So I sat with her on the phone for more than 2 hours listening to her story. And I guess I want to share that this morning to say, if you are ever in any doubt about the kind of impact that sexual harassment and assault has in the services that you're all accountable for working in and running, don't be in any doubt. This can absolutely devastate lives. And I wanted to say that, and that this brooch I'm wearing today is to sort of bring the spirit of the many survivors who are living with pain, injustice, not having been believed, and some of them who aren't even with us anymore, to bring them into the room. I wanted to acknowledge 2 tragic ironies, one of which has already been acknowledged this morning in the findings. So the first one that's already been spoken about by Helen and Jayashri in particular is that the vast majority of us who come to you for help already have a history of trauma. And very often that's gender-based violence, it's child abuse, it's family violence. And the terrible irony is that the very thing that broke us in the first place is what happens to us again in the place that we've gone to for help. And that can't be okay. And the second really tragic irony, it's bad, the first is bad enough, is that the vast majority of us are still forcibly detained in services. And we're told that that's done to keep us safe. We're told that that's done because it's in our best interests. And what this report reminds us of is that is patently not true, and we need to acknowledge that. So sorry, that's just really emotive for me to say, but it's really important. It needs to be said.
And just to clarify that, you're saying it doesn't keep you safe because in the place where you're supposed to be safe, your rights are being violated again.
Absolutely.
Is that the point that, that's the important link?
The important point is, and look, very sadly, sexual assault and harassment are not the only unsafe things that happen to us, but they are profoundly unsafe. But I just want to quickly also say with the findings that it's not a surprise. It should not be a surprise to anyone here. This is an enormous long-term systemic failure. Mental health services and government have let down consumers over many years in not keeping us safe. Do I have a moment to briefly reflect on the reflections, on the recommendations as well?
Yes, indeed, I want to ask you, what are your thoughts about the So this is there are findings, but there are recommendations. What are your thoughts about them?
Thanks. So this is, and I'm speaking personally and from VMIAC when I talk about this. But again, 3 points. So the first one is that by and large, we absolutely support the recommendations of the Mental Health Complaints Commission, and it's long overdue for this system to have this investigation. We're very glad that it's there. But by and large, we believe many of the recommendations need to be strengthened in different ways. And so over the coming weeks, we will give a formal response to that after we've had time to consult with the broader consumer community about what people who've survived this want to see, who haven't had a chance to speak yet. And just to give some examples of what we mean by strengthening, one I mentioned this morning, so of course we need to improve reporting. It's astonishing that we've known about this for decades and we don't even have data. But we know from the Royal Commission, we know from many other spaces, that when terrible things happen and they're kept in secret, they don't change. This has to be reported in the public. It should be in the department's report to Parliament every year. And I want to know, and I want all of the people I care about to know, because I can't choose my catchment area for a mental health hospital. So I want to know what the rates of sexual assault are at my local hospital, because if I can't stop the chance that I might end up in there, I will move house, and I have the right to know that. I want to know what they've implemented to keep me safe.
So you want openness, you want more transparency in terms of information about where things are happening and what's happening. Absolutely,
and if the initial report says we don't have that data at the hospital, I want to know that too. And people have a right to know whether they'll be safe or not in our public services. Another example would be women's only units. We wholeheartedly support the need for single gender units, but we believe it's not enough for us to pilot these over the medium to longer term. It's entirely possible that we could open some units this year with the right level of funding and commitment, and we should do that. And in the meantime, we can take other steps. So we can make high dependency units single gender because they're one of the most unsafe places. We could do that on Tuesday if we had the commitment to do that, so why don't we just do it? And in terms of the strategy, we're just, and I don't think I'll be speaking just for consumers, I think clinicians might well feel the same, that we are weary of documents. I am so tired of documents. Of course we need a strategy, but a strategy will not be enough, and I'm very concerned with government-produced documents, that the risk that it will be politicised to the point that it no longer has any meaning, or that it will be co-opted in ways so that it has the wrong meaning. And even if we have a good document, we all know that there's no guarantee that anyone will read it or do anything. I know full well that many of the guidelines that come out of the department are not read by people at all and are not reflected in practice. So we have to see a commitment of serious funding. And Margaret Grigg told us this morning that 35 million won't build anything, so we'll up our ask. We have zero tolerance for occupational violence. We want zero tolerance for sexual assault. We need a systemic response as well for historic survivors of this. We learnt a lot from the Royal Commission that Helen spoke about. There are thousands of people who've survived this in our service system. Where do they go to testify about what happened? to be witnessed, to get healing and support, or even to get justice. We need to think about that and respond to that. And that's very serious because that will begin from next week when this moves into the public space. And what are we going to do for those people? We need deep, sustained structural change, which is not a framework, a 2-day course and a poster. And if we don't have consumers involved in a very large way from the very beginning, this will fail. So they'd be my key messages.
All right, thank you very much. I'm going to move to Julie Dempsey now, and you've done a lot of work with women regarding their mental health in acute mental health inpatient units. What have you learned, and how does it dovetail with the recommendations that are coming out of this, the Right to Be Safe report?
Well, unfortunately, the project documents very similar experiences to what we've encountered over decades from talking to consumers. Namely, inpatient units are often perceived and for some practically experienced as threatening, unsafe environments where you have to tolerate or even fight off sexual harassment, intimidation and abuse as part of a process of getting basic treatment for your mental illness. Lynn mentioned the importance of language and clearly identifying when assault occurs. I think consumers have been loud and clear on this for decades. We need services to take this on board. If someone does not speak up, then we need to make it okay to do so. The network conducted surveys in 2006 and 16 on consumer and staff experiences of safety in inpatient units, and we particularly wanted to see the effect the women's only corridors had. And in line with the Mental Health Complaint Commission project findings, these figures are alarming and would be totally unacceptable anywhere else in the health sector. So why is it acceptable in the mental health sector? 68% of consumers felt unsafe during their stay. 56% of staff noted that consumers felt unsafe, so we're not blind to what's going on. 55% of consumers experienced harassment, intimidation or abuse by another patient, and 56% of consumers witnessed this. So it's not just the consumer it's happening to, it's the whole environment that everyone's exposed to. 85% of staff reported working with consumers who had experienced or witnessed harassment, abuse and intimidation. 43% of consumers felt they were not treated with dignity, and 60% of consumers said their hospital experience was actually traumatic. This all sounds grim and negative, but could I just touch on the Sexual Abuse Commissioner's comment about the importance of relationships? I have a litany of horror stories I could tell you about transgressions in inpatient units. But for me, the thing that has made, for me personally, the thing that has made the difference has been relationships. It has been a few key relationships with significant people in the system, and this could be a nurse, it could be a cleaner who stops to talk to me while she's emptying the ashtrays. We're going back a few decades here, but you know, just someone taking a genuine interest, having 10 minutes to sit down and talk to you during a whole 8-hour or 12-hour shift or whatever it is. That can make a really big impact. So that is something you can do personally. You don't have to change, you know, people say it's too hard, we can't change the system. Well, you individually, right from this point going forward, could change a consumer's experience by connecting with them, as I spoke about Helen and Jay Shuri's talk, in a humane and caring way. I know everyone gets not everyone, a lot of people get desensitised by the system. But if we could build into the system structures to support consumers and staff to move forward in recovery journeys together, and I think a lot of it is in opposition at the moment, especially with involuntary treatment, then I think we could go a long way. And a basic example of this would be to have barbecues. So well patients could come back and have a barbecue with the staff on the unit, and they could see the product of their hard work. They could see someone well instead of just seeing them in the revolving door of crisis and thinking this is all too hard. So anyway, the key issues behind these figures are numerous and complex. Women-only spaces have made an impact and could be so much more effective if used as initially intended. For example, bed pressures result in males being put in female-only corridors. The corridor then ceases to be a female space. I would argue that these female-only beds need to be mandated. Ideally, we would have female-only units. For me personally, I would like to walk into the day room and not be confronted by a man partly undressed and with his hands down his pants, or to start up a conversation with someone and not be asked, do you want to get it off in the bathroom? These are just basic things I would expect in a home environment, and to go out in public and have the opposite thrown at me just doesn't seem right. So we need clear direction from leadership and training for staff to follow up on gender matters. Now there appears to be confusion and huge variations on how gender issues are addressed or not. Structural improvements need to be reinforced by positive and educated culture change. So I've got some more points, but I want to give other people a chance to speak. They're just some of the similarities.
You know what? Thank you for that. That is so. That's so respectful and kind. It is. We have many voices, and we will not be able to hear everything. Hopefully, we'll have an opportunity to come back. Thank you for that. I'll move on to Katrina Clark, if I may, and I want to talk about the services and how families and carers can interact. How can we make it safer for people to have safe passage, in Helen's words, as they go through the system? How does that happen?
Well, we need to seek family carers' views from admission right through the planning and into discharge. Particularly where if a person is not able to, we need to include and seek family carer views right from the outset, to avoid this from occurring. To seek the relevant history, that they may be able to inform treatment and safety planning. Involving carers early and right throughout the discharge planning, ensuring appropriate referrals are made as well, so that not just for consumers but also for the family care member. So being able to link them to services that actually will provide ongoing support, particularly in this short-term acute care setting, that we actually provide that ongoing support there. And planning for admission to a different future. If this has happened in the past, let's not admit people back to the same unit if that's not helpful for them. Being able to actually refer them to a different area if a breach has occurred.
What about any sort of difference based on age? I mean, you've got a population, the report focuses on adults, but we also have people who are older, who are younger, and adult includes a range from 18 on up. Are there any differences or distinctions based on the age of the consumer?
There definitely is, and a couple of things come to mind. One, I've had some discussions this morning in actual fact about that with some colleagues in the carer space, and in a youth unit, adults are being admitted to youth unit wards. That's not helpful. Also, parents, sometimes there's a disconnect between teenagers, adolescents and parents, and the fear, I think, of reporting, the fear of actually speaking up because the parents might find out. Also, particularly where there's culture involved, can be very fearful, and parents often don't know. Parents are often the person too who think they're bringing the person to us, seek support, seek services, and actually may take some of that guilt if it is found out as well. So parents, where they do find out, carry such a burden of guilt for actually seeking that service. And
so how do you resolve that? What's your suggestion quickly for trying to resolve or minimise that challenge?
Yeah, so there's a couple of things. So family inclusive practice, and we know that it's talked about, it's one of the hot topics, but are we doing it and are we doing it well? We know that the Office of the Chief Psychiatrist has guidelines that support services in how to do family inclusive practice, how to work with families and carers and support people. Yet, is that just a piece of paper again? And, what are the strategies and what are people actually doing? And I encourage you all to go away today and actually start doing it. Let's not talk about it. Let's not wonder how we're going to do it. But we must involve families and we must involve them from the outset. I also fear the impact on peer support workers if it's left to them to do this job all the time. We need to actually step up as services and actually implement and do the practice every day.
All right,
Thank
let me
you.
move, if I can, to Brenda Appleton, because I think we've talked some, but really only around the edges, about individuals who are trans or gender. What are the challenges? There's been a lot made of the potential of a single-sex unit, so a women's unit, a men's unit. What about a trans or gender person in that environment? What are the challenges and how can they be addressed?
Thank you. Trans and gender diverse community is a vulnerable community, just like many others. And if you're not aware, I'd encourage people to perhaps have a look at trans pathways. It does help emphasise just how vulnerable our community is. Survey of people across Australia, nearly 1,000. 48.1% had attempted suicide by the age of 25. A very vulnerable community. Being trans and gender diverse means our gender identity and or expression differs from society's expectations. Our sense of gender doesn't align with the sex assigned at birth. All too often today, forms only have male and female. All too often we experience being referred to in the wrong gender, the wrong pronouns. We need to be validated for who we are. So a safe space for us needs to be one where we feel safe, safe to be ourselves. And all too often it's not the case. Many of us have bodies that don't align with society's expectations. So being an inpatient means that we want to be in a safe space, safe for us for our identity, safe for us for our body. We want privacy. We don't want to become a point of ridicule. We want to be respected as a human being. I like the title, The Right to be Safe. It is a human right, and we've got the same rights as everybody else. In our community, we have a high incidence of neurodiversity. Depending on the survey, 25 to 30% can also be on the autism spectrum. Communication becomes a huge issue for us, particularly dealing in medical situations. The trauma that we experience makes it often difficult to advocate for ourselves. And for those suffering neurodiversity, it adds to that problem. So one of the things we would like to see is more access to advocacy. Often we're estranged from our own families. We need recognition that family of choice is as viable as family of origin. We need direct care directives to reflect, to be honoured and respected. We're finding instances in our hospitals today where medical care directives are not being honoured by hospital staff. And for someone who is struggling to advocate for themselves, to then be told that that's not a valid form that we'll recognise, adds to the complexity of the situation. Toilets should be a straightforward thing. We would like toilets to be gender neutral. Not being able to access a toilet that fits your own presentation is very troubling. And the other bit that I want to talk to out of the trans pathways, in this cohort, 48.6% identified as non-binary. So outside of the male-female binary. So their needs, people sort of get people like myself. I was assigned male at birth. I live and present as a female. I'm happy in that. I'm a very out and proud trans person. But for our gender diverse people, for our non-binary people, it's another burden for them. And I find governments, medical providers and others just don't get that you could be other than male and female. And therefore the burden that they suffer is even greater. We need to be mindful of that when we're looking at single gender wards. We need to be mindful that there needs to be a space for people that don't identify as either male or female. How do we keep them safe? So I guess privacy, access to appropriate services are just huge issues for us. And I find on the whole they're not being addressed. Our community is relatively small, somewhere between probably 1% and 3% of the population. But it's a population that is coming out more and more. We are using services more and more, and those services are failing us at the moment.
May I ask you, in terms of this conversation and the recommendation in the report that there be more single-sex wards, where do you want another or third ward, or do you want would your recommendation, and this would be for you, be for people to have a choice to identify which ward they chose to be in?
So certainly I think a choice is a good starting point. I think some people will not feel included in either a male or a female ward, and therefore some single rooms would be necessary to accommodate them.
All right. That's very helpful. If I can go to Sandra Keep Arnold and Penny Herbert, I've got you two together, but you may... Are you being...
Tag team.
Yeah, I felt like that from the way it was scheduled or sorted here. I want to talk about the work being done at the Alfred. You guys are sort of right at the coalface in some ways there at the Alfred. What are you doing in relation to this issue already? Has the work begun?
Yes, it has. I'm going to just have to reach over here, Sandra. I guess the thing that we have looked at is we did have an opportunity at the end of last year to just stop and pause. So acknowledging the speed and the pace that the inpatient units are working under and the pressure that they are under, we had a situation where just what would be seen as usual business, review a guideline, tick it off, send it off and activate it. And it caused us a point of reflection and stopping and reviewing what we had already in place. And I was very pleased to hear this morning the recommendations, because it was probably the areas of work that we identified were missing in existing sort of guidelines and structures for the teams, and knowing what to do, when to do it, how to do it. So from there we really have carved out some time, and with our consumer consultant lead Catherine, we've met with some consumers from the service. We've had about 3 or 4 focus groups talking about what the experience is like in the inpatient unit. And one of the most striking things, I think, for the working group that we're working with around this is the stories and the awareness that people report about understanding what's appropriate, what's not appropriate, what are the rules around that. So that really ties in with the orientation information. But also, there is an issue around environment. Tired units, configured in the 80s, built in the 90s, not fitting need at the moment. And also one of the key things we heard was about the overnight safety. So the safety overnight was a really striking chord, and particularly in the setting we don't have en-suited rooms. We have 3 or 4, but the rest are all shared bathrooms. And hearing stories of people waiting all night not to go to the toilet, to open doors, to go out into the hallway because of the trigger of someone else hearing people up was a very powerful thing for the group and for the organisation and the team, I think. So we've really just stopped and gone, okay, we have to think about this quite differently. This is not just about one impact or one action or one thing. It's about people feeling safe in the space. And some of the things we identified was around prevention, and certainly the consumers we met with talked about that a lot, sort of what can be put in place. People asking me if there's anything concerning me. Some of the anecdotal stories of reading documentation that says that this person slept in the group room there's the first flag and trigger that something is happening in shared rooms particularly that is upsetting that person, and understanding how to respond to that. So we're really spending time right at the moment, and the timing of this is fantastic because it builds on what probably the first foundation working group had started to identify as the gaps around what we need to put in place. And one of the things that the Alfred has done is around their managing aggressive behaviours. So they have a psychiatric BOC call, which is a behaviours of concern call. And they have, in the last 12 months, their 2 inpatient units reduced their seclusion down to the lowest rates ever, I think, in their lived memory of most people in the units. And that was really a full prevention model. So a lot more work, a lot more effort going into seeing early behaviours and responding differently rather than waiting for it to blow up. And that's really where some of this work will sit, is around prevention, identifying behaviours, identifying sort of activity on the ward, or people reporting feeling unsafe, and what will happen in that. So that's been really good that will line up with that, I think, as one of the outcomes we have, but we're still working on that. It's still a work in progress, and I think the recommendations we've seen today will really help strengthen that approach that we're taking.
So if I can just add to that, because I am the Director of Nursing, and so obviously I've got particular interest, and I think one of the things that resonated me, when Julie was talking about, was the connection, that can make an enormous difference for anyone when they're, sort of a consumer in a mental health service. It makes a difference if we're connected to our teams as we work. It makes a difference if we're connected to our nurses or the staff that look after us or contribute to our care while we're in hospital. So part of the work that we're doing now is actually also to look at the model of care. So I think that this is a conversation that's had all of the time. What's the nursing model of care look like? What's the nursing delivery care system? What is it, and how's it articulated? How do we deliver nursing care? And I think nurses have always done and will always do what we've always done, unless we start to become very prescriptive and start to think about doing things differently. And I was absolutely horrified when I started to hear these stories about how consumers felt unsafe at night time. And yet I read nurse reports that say a consumer slept on the lounge, they, stayed out all night and slept in a chair, and there's been this genuine acceptance that seems to be okay. And so I think it's about how do we start to really unpack that and have the spirit of inquiry that's really critical in terms of understanding what the drivers are and ensuring that we unpack the informations and deliver different care. And so, one of the very first pieces of work that we're doing now is starting to look at what is that model of care. How do we prescribe? How do we create a Bible? I'm very conscious of the fact that nurses now spend 3 years in undergraduate training with about 40 hours of mental health nursing content. They arrive on our wards with no knowledge about how to connect with human beings. Our whole effort has got to be in how we develop and upskill staff to be able to have those relationships that absolutely make people safe. So, we've got a lot of work to do. This is the beginning of a journey, and I think as a nurse manager for many years, I'm not proud of the fact that, the system has failed so many people. But I think that through the current work we're doing at the Alfred, through some co-design methodologies of actually hearing and listening what matters to consumers, we've actually got an opportunity to change the way we deliver nursing care in a way that's meaningful to them, rather than us having a top-down approach about filling in the forms, completing the documentation, and doing that base work. So I'm sort of proud of the work that we're doing. As Penn said, the work around SIBOC has taken us from a seclusion rate, and I'm horrified to tell you, but that at 15 years ago was 78 episodes per 1,000 bed days, and we delivered on an episode of 1 episode per 1,000 bed day in January. So, I think the work we do, we can achieve the outcomes through, the processes we're taking.
Thanks very much. I'm going to move on because I'm watching our clock, but we've got Anna Love next. If you can tell me what's being done so far to make the inpatient units safer, specifically to talk about the right to be safe.
Yep. So I'm going to address probably just a number of things which are happening out of my office, the Office of the Chief Mental Health Nurse, in conjunction with the Chief Psychiatrist. And probably the first thing to say is that, when we were listening to the presentations this morning, we heard about HDUs and about how many assaults are actually happening in that area. And that's been an area of concern for me for a long time, having worked in a service that had probably one of the smallest HDUs in town, and being really concerned about the models of care that we actually could provide in that space. So it's about a moment in time, so we also have guidelines that need to be reviewed, and we had a chief psychiatrist guideline that was to do with HDUs, which was written in 2002. So it's time for review. So with that discussion about review, very quickly it became very clear that it wasn't an HDU guideline that we needed anymore. It was actually to start talking about mental health intensive care, and that was a framework that we would actually, as nurses, work to. Nurses, doctors, allied health, that we would work to. So that's in discussion right now about what that framework can look like. But it's actually to move a culture. To move a culture from thinking about just a space where we actually put all our problems, because that's what it seemed to be, that in inpatient units the HDU was seen as the place where problems went, where we said that we were protecting people, but we really were not, and we are not. We were putting very vulnerable people in with very vulnerable people. So we're in discussion about developing that framework, but at the same time, I felt that there was a need right now to start a different dialogue with staff about what mental health intensive care and what it meant when you were in an actual mental health intensive care area, so that locked space, if you want, in units. What could that actually mean to work in there in the future if we were going to do something different? So we started a piece of work at the same time, which is to look at a training package, and we've got the opportunity to do some training with one of our regional services in April and May. So we're in a process in our office of co-designing a training package to do with mental health intensive care, and I'm really pleased to say I have Julie Anderson in my team, Frances Saunders in the team, Kate Thwaites, Nicole Edwards, working intensively about how to actually put together this training package. But we also included and actually asked for the assistance of Vimiac and Tandem in relation to this. So we have a number of videos that have been produced, which are the most powerful videos I've actually seen in a long, long time. Because it's consumers and carers and clinicians talking about their experiences of high dependency unit care. And they're all saying the same thing. They're all saying how awful it is, how terrible it is, how untherapeutic it is, and that they want change. It was powerful because we're actually, I want to say this, and I don't mean this in a disrespectful way, but you actually watch the videos and listen to the stories and you don't know who's talking. You don't know whether it's a consumer, a clinician, or a carer, because we are all talking with the one voice. So that gives me hope that we actually need to and want to change, but change is what we actually need to do. And what we want to do is actually move from a culture, and I'm going to again use Indy's words here, a culture of control to a culture of care. That's where we need to go. The work that we're also doing around safe wards is another piece of work which just builds on this. So a lot of the work that we're doing at the moment I just see as building blocks to a bigger picture, which is the change of the culture of inpatient units as we know them now. Safe wards, as people in the room know, is about providing a safe environment for all. And, I thank all services that have embraced the safe wards model, and I thank the training team, and, again, I have to thank consumers about their input into that training, and especially to Indy, actually, who actually brought the consumer voice very much to the fore of that, of the training now that happens across the state around safe wards. We looked at the gender-sensitive training. I think it's been mentioned about trauma-informed care. Should we make that mandatory? And I think one of my colleagues, Nino, has already made that comment that we actually we've got training packages, and what are we doing with them? And that certainly was my sense when I went into the office, was we have a training package around gender-sensitive practice, but it had been diluted across the state. So we've worked with the Women's Mental Health Network to, first of all, do a bit of a refresh. So they actually undertook 7 sessions of training across the state, which every service actually came to, which was good. And that training was about talking about what the Chief Psychiatrist guideline is right now around gender-sensitive practice and sexual safety, but also asking the participants to talk about what they might see for the future and give some recommendations, because again, that's a guideline. We've got guidelines that need to be reviewed. Those sessions produced lots of rich material, which we now will use into the future for reviews of guidelines, and we've also shared those with the Mental Health Complaints Commissioner. And it speaks of the same things. It speaks of staff actually being unclear of processes, being unclear of definitions, what's sexual assault, what's sexual activity, people not being sure about processes within their own organisations or processes within the state about actually reporting. So we're going to use that information as well as the information that's come from the Mental Health Complaints Commission report to review our guidelines. But at the same time as reviewing guidelines, we don't want to just produce another piece of paper. We actually have to think about implementation and training of staff, and that will be the journey that we will now embark on. The other aspect is, and again this was said this morning, for staff to be in a culture of care, we actually have to care for our staff and care for each other. So another 2 important pieces of work that I think that we're finished actually, is the clinical supervision framework for staff, for nursing staff in particular. Nurses are actually their world's worst enemies. We just carry on. We carry on in task, and we work in teams, and we don't want to leave the floor because we'll leave people, uncared for. But we need to change that dialogue with each other, because we need to look after ourselves, because we can't help those that are in need of help and our assistance unless we look after ourselves. So there's a new clinical framework for supervision that's been developed, which will be launched at the AXA conference in May. But hopefully that will actually now articulate very clearly, both to individual nurses, but also to services, about what your responsibilities are to allow staff to actually have supervision, to have time to reflect on their practice, so that they can actually re-energise themselves to come back to care for those that they need to care for. Another piece of work which has already happened was a pilot of some resilience training. Again, this is about supporting our staff to be able to come and do the job that they need to do. It's a hard gig working in acute inpatient units in year 2018. I know I've worked in inpatient units for a long, long time, and I think right now is probably the hardest time ever, with all the things to do which we've been talking about, but also, drug and alcohol issues and what that's actually meant in our environment. They're hard places, and again, our staff need to be supported. So through the Australian Catholic University and Kim Foster, she's done a pilot with some staff around resilience training, which got really positive results. We're now going to be looking at a bigger rollout of that training across the state, so that's coming. As we said, the Chief Psychiatrist guidelines are going to be reviewed, and along with that, there are a number of other guidelines which are being reviewed. And I think what consciously we are now doing is being very careful whenever we review a guideline that we continue the story, that we don't just do a guideline in isolation, so that discharge planning has to be connected to treatment, has to be connected to leave, has to be connected to gender-sensitive practice, has to be connected to everything that we do. So we are making, and hopefully you will start to see, a conscious effort of actually us linking that material together. Lastly, the other thing that I would say about training, we talked about trauma-informed care. And yes, there was a trauma-informed care package of training that was produced at the time of the change of the Act, and along with a million other pieces of training that were rolled out at 2014. Yes, I think it has been forgotten. Many services have used it in little bits and pieces, but really we haven't actually taken it on full-heartedly to say that we're training staff in trauma-informed care. And really, what is it? And I know, again, I've had discussions with Indy and with Julie in our office about what does that mean and what's that going to look like for services. I think we now need to turn our attention to do that. I think we need to do it well. I do think we actually need to agree that we need staff who are trauma competent, but we need to listen and work with our consumers and carers to get that right. So I'll be looking for assistance from VIMIAC, from Tandem, but also from all the clinicians out there to get that right, so that we can actually produce something that is going to make the difference to the consumers that we work with.
I see that you've got a response. We'll make it quick because we've got one more person to talk, and then we've got to wrap the panel. Thanks, Julie.
I just wanted to ask Anna, you're talking about things that have been identified by a lot of people needing supervision, clinical supervision and training that's not just an add-on to fit somewhere in your busy schedule to make it meaningful. Will the department be funding mandated times for these things? Because some services already say they provide all these things, but when it comes to the push and grind of the day, the nurse never gets there, they forego their supervision.
So is it being funded?
So what I would say is it's part of our industrial agreement. Now we can look to my A&MF colleagues there in the audience. It's there. It actually says it's mandated and that services need to provide it. So services need to find a way to make it happen.
All right, we're going to follow that up. I want to get to Danielle O'Connor because you've had an opportunity, you've already been doing things, and then you've had an opportunity to listen to this conversation today. What's already being done by the Office of the Chief Psychiatrist, and what are you going to go back and call your staff in and say, we have to do this differently now because of what I heard today, and what are you going to do?
Well, some of you...
Other than that, I don't have any questions.
We've started already. Some of you might have read the report written by Stephen Duckett. It was called Targeting Zero. It was a report commissioned by the Department of Health and Human Services to comment on its quality and safety processes. This was 2 years ago, I guess. It wasn't just to do with mental health, it was across the board. And what Stephen Duckett said was, department, you're doing a rubbish job. Really, you're very good at collecting data on squillions of things, and everybody here who's a director or a manager of a service will know what that means. You collect this information, and what do you do with it, unless it's to do with dollars and KPIs and so on. If it's anything to do with the quality of your care, do you act on it? Where does it lead? And the truth was, and this would apply to the Office of the Chief Psychiatrist too, I'm afraid to say that a lot of it was just parked. And that has changed. So over the last 3 years, there have been really huge endeavours to look in a really meaningful and creative way at the data that we collect on reportable aspects of clinical care, like the deaths of mental health consumers, for example. Services have to tell us about those, about restrictive interventions, restraint and seclusion, and about ECT. So we now look at that, we try and make sense of it, we map it. Where are these things happening a lot? Where are they happening hardly at all? What does this mean? If a service is telling us that a lot of something is happening, it might just mean that they're really conscientious about, telling us about things. It might mean they're doing a really, really, really good job. So in making sense of data, you really have to put it in context, which will mean picking up the phone or actually going to visit a service and to say, look, what you're doing looks a bit funny to us. Let's work with you to understand what that could amount to. Is it a reporting thing, or are you really using something, restrictive interventions, for example, in a way that really is unusual and really worrying, and we're going to work with you to change that around. So sexual safety is on that list now, and as of this month. Services are, because we know that services have been asked to report on sexual incidents of sexual assault for a number of years now, but the reports coming in have been very few in number and very patchy. So it was obvious, really, when you thought about it, that it was just massively underreported. So how could we have known what was going on? We weren't told.
But in a way, how could you
Yep.
not?
Hmm?
In a way, how could you not?
Yes, so that, anyway, as of this month, services are being asked to tell us in writing of every episode of sexual harassment and assault, and to provide us with information about that, who and where and what was the context and what part of these are adult inpatient units, what part of the unit did it happen in, and what have you done about it? And there will be a checklist to remind the clinicians of what we in our guidelines expect them to do once an incident has happened. Have you made this person safe? Have you made efforts to keep them safe? That might mean separating people. It might mean somebody having to go to another inpatient unit. Is this person physically safe? Have they been offered a physical checkup? Have you debriefed them? Have you given them an opportunity to talk with you about what happened and the impact that that has had on them? Are they consenting to your talking with family members about this, for example? Has there been open disclosure? What is your executive doing about this to understand the incident and to prevent it happening again? So that is starting. So we will collect data and really keep on reminding people not just to report incidents, but actually to think carefully about a response. And the idea is, with respect to the data, to analyse it, to make sense of it, to look at where things are happening, to understand that, just as we do with the other reporting requirements, and then, if need be, to go and visit and to say to people, this looks odd. What is happening here? How can we work with you and support you to turn that around?
Do you think governments in general respond to the something that comes at the access of data and personal narrative? We saw that with the Royal Commission. Personal stories backed up by horrific numbers. Is that what needs to happen to move the dial, to get the money, to get the support, and to make the changes?
Well, government departments are, as I say, very good at collecting data, and we do, and I think we are now absolutely committed to acting on it. I suppose where those narratives emerges in services, at the place where things go wrong. So if staff are really engaging with consumers, if they are observing what is happening, if they note that something bad has happened, and they're sitting down with people and saying, oh my God, how are you? How are you managing? How can we make you better? That's where those narratives come out and will be heard by clinicians and responded to by the people on the ground.
I think this is a great group in our panel. I'm sorry we didn't have time for everybody to say more, but believe it or not, we've already gone beyond our time limit. So sure. I would encourage everyone, write questions on Slido. If there's something that has been brought to mind by what you've heard, do write that question, because those questions are going to the Mental Health Complaints Commissioner and they will be answered, and that then becomes a part of this conversation. It doesn't all happen today in this room. I'd like to give a big thank you to all of our panelists.